This is TTT Live. I am DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the Manager, Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning, Trinidad and Tobago. You are tuned into another virtual media conference hosted by the Ministry of Health, which will provide an update on the national COVID-19 response from a health perspective. Our panelists today are the Honorable Terence Dayal Singh, Minister of Health, Dr. Roshan Parasram, Chief Medical Officer, and Mr. Davlin Thomas, CEO of the North Central Regional Health Authority. I'm Candice Alcantara, Manager Corporate Communication at the Ministry and your moderator this morning. We begin with some important opening remarks from the Minister of Health.
Thank you, Candice. Good morning to the Chief Medical Officer, Dr. Parasram. Good morning to the CEO of the North Central RHA, Mr. Davlin Thomas. Good morning to ladies and gentlemen of the media and to the wider listening and viewing public, wherever you are on this, it is still Ash Wednesday, but it is Ash Wednesday. People will be going to church to get their ashes, very important day. Ladies and gentlemen, today, Wednesday the 17th of February 2021, marks the beginning of when Trinidad and Tobago takes control of this COVID pandemic. What we have been doing so far is managing by the institution of public health measures through regulations, namely the wearing of masks, the social distancing, staying home if you are ill, all those wonderful measures where we manage the virus. The virus could still hit back at us. We push back on it. Many countries close to us, unfortunately, are not in a good place as we are. And we stand, with our brothers and sisters around the world. Our rolling day, 7-day average right now is 6 cases. That is a pretty good place to be. But that is only due to management. There are still some parts of the economy that are still closed. For instance, daycares. Schools have reopened in a partial level. Nightlife is still curtailed a little bit. And we really thank those industries that have been bearing, an uneven part of the burden for their understanding. But today, we move from managing the virus to controlling the virus, a very important distinction. In controlling the virus, it means we can do several things. It means we can further decrease our 7-day rolling average. Importantly, we could decrease mortality, especially amongst our elders. And hopefully, in time, we can't say when as yet, in time, many more sectors of the economy can go back to normal. Life can go back to normal. You can hug your grandparents, kiss your grandparents, attend your birthday parties. You can have your weddings, and so on. But to do that, we must move from these physical measures, social distancing and so on, to pharmaceutical interventions. And using interventions like vaccinations, which have been used for centuries to manage, control, and defeat diseases like polio, whooping cough, yellow fever. The modern age of vaccination started in 1796, when Edward Jenner came up with the smallpox vaccination. And vaccinations have been used for centuries to save lives, save people from contracting polio, and so on. So today, we start the rollout of our vaccination program, mainly targeted to the highest risk individuals, which are our frontline healthcare workers. These are people with the highest risk due to high exposure working in our facilities that treat COVID-positive patients, namely Couva, Arima, Cora, and Augustus Long. So we are targeting today our high-risk, high-exposed persons. Last week, Wednesday evening, I believe it was CMO, we received 2,000 doses of the AstraZeneca vaccine from Barbados, which was part of a wider gift to the area. These vaccines were sent to Trinidad and Tobago free of charge, so we did not have to pay for them as part of our allotment of this gift. We had to wait until WHO signed off on what is called EUA or EUL, which is Emergency Use Authorization or Emergency Use Licensed. So the vaccines came in last week, Wednesday evening, after our press conference, but WHO only signed on to it on Monday, February 15th, which is Monday gone. 2 days later, we are in a position, having received that sign-off, that seal of approval, which more or less guarantees safety and efficacy, to start rolling it out to our most cherished population, in the first instance, our frontline healthcare workers. Vaccines have been the global response to healthcare threats, as I said, since 1796. Today, Wednesday, 17th of February, marks the day when Trinidad and Tobago, as I said, takes control of this virus now. It is imperative that we offer this first 2,000 doses to those who have been doing human service and who are, as I said, high risk, high exposure. We start the program today at the Couva facility. Mr. Davlin Thomas will speak more about that. And what we are using this as is to show healthcare workers several things. One, the government's need to care for them by giving them first bite at the cherry. Two, to demonstrate safety and efficacy. Three, to set the ball rolling and to have these persons who are being vaccinated today show to their colleagues that they have total faith in the vaccination program. So that is where we are today. It's a red letter day for Trinidad and Tobago as we join the, I think it's about 34, 50 countries now that are vaccinating people. Not all, but we now join that sort of exclusive list of people using vaccines, but we are only using vaccines that have been approved by WHO by either EUA, Emergency Use Authorization, or EUL, Emergency Use License. There are other countries that are using other vaccines that don't have this stamp of approval. But we have been consistent from day one in saying we will only use vaccines that have the WHO stamp of approval. So today is an excellent day for Trinidad and Tobago. I look forward to answering your questions, and I will see most of you all down at Couva for 2 p.m. later on this afternoon. Thank you very much, Candice.
Thank you very much, Minister, and some wonderful news this morning. And we go to Dr. Parasram now, who will present the clinical update and also give us some additional information on the vaccination program.
Thank you, Candice. Good morning to Honorable Minister, Mr. Thomas, members of the media, members of the viewing and listening public. I will just go through the clinical update first and then give some details on the vaccine itself. So with regards to our persons tested so far, we have 92,508 at this point, with a total positives over the last 24-hour period being 10, taking our grand total up to 7,656 persons being positive since the 12th of March. In terms of our recovery, we have 7,362 of those recovered. Total cases, active cases at this point now stand at 156, 138 deaths recorded thus far, and we're down to 21 patients now at our facilities, both in Trinidad and Tobago. With regards to our step down, we only have one individual at step down at this point in time, and at a quarantine site as of this morning, 296 persons spread among 10 facilities. In total home isolation, there are 124 persons at this time. With regards to the hospital data, so the majority of the cases are at the Couva Hospital and Multi-Training Facility. We have 19 persons there, 3 of which in ICU, no persons in HDU at this time. 2 persons left at the Cora facility. There's no one in Arima, no one in Augustus Long, and no one in Tobago at this point in time. The one patient in step down is at the UE Daybay site. With regards to our quarantine, 296 spread amongst 10 facilities. The facilities are the Chancellor Hotel, 10, Cascadia Hotel, 25, Regent Star, 34, Aria Suites, 20, Daybay Halls, 23, Freedom Hall at UE, St. Augustine, 53, Cara Suites, 21, Capoc, 77, and the Napa, 26, with Tradewinds Hotel having 7 persons as well. So to go into a little bit of detail, we would have gotten the Pfizer vaccine approved on the 31st of December, I believe, by EUL. We now have the AstraZeneca vaccine, which is the second vaccine approved by the WHO under EUL, EUA. And just to give some interim guidelines for use of the AZD1222, which is AstraZeneca, it has been approved with 2 manufacturing plants, one in South Korea and one in India, which is the Serum Institute of India in that case, where our donation of 2,000 vaccines would have come from. So it has received EUL for that particular site. With regards to the vaccine itself, just to give you a little background, it is a vector vaccine, which is an adenovirus platform onto which the spike protein is added to take it into the cells. So a vector type vaccine, it is that particular platform usually gives a good amount of antibody formation, a larger amount of antibody formation, as it resembles an actual acquired infection. So we find our storage for that particular vaccine is 2 to 8 degrees Celsius, which means it can be stored at a normal refrigerator temperature, which is very good for distribution. It also, once you puncture the vial, which is a 10-dose vial, so you have 10 persons can be vaccinated from one particular vial, that vial needs to be used up within 6 hours after the initial puncture is done. In terms of categories of persons that can and cannot be vaccinated, the interim guidelines says, and we discussed a little bit of it earlier on in the week, for pregnant patients and breastfeeding mothers, Dr. Surjit Singh would have been on, and Trinidad's position at this time is not to have that category of persons vaccinated out of an abundance of caution as the data continues to come in. With regards to persons under 18 years of age, those won't be vaccinated as well. With regards to our booster dose, we're looking at 2 doses for this particular vaccine. Based on the research, it is recommended that the second dose come at least 8 to 12 weeks after the first dose to give you the best immune response. In terms of contraindications, again, the main contraindications are the age and, of course, pregnancy and breastfeeding, along with persons who would have had allergic reactions to components of that vaccine or a previous dose of that vaccine and had an allergic reaction to that particular vaccine. For persons over 65, which was a little contentious in the European region, WHO has said that they are recommending that use above 65 be done, and in Trinidad's policy, we are going to use the vaccine from 18 years upwards. There's no upper limit to stop. Persons with comorbidities with regards to NCDs like diabetes, hypertension, those are our high-risk patients. It is recommended for use in those patients. And finally, I think with regards to persons who have had previous COVID infections, so those who would have been COVID positive, for example, we are asking, and the recommendation is that we wait for at least 6 months after the initial infection has subsided, and then you can have your 2 doses of vaccines. So, Ms. Alcantara, that's my clinical update for this morning.
Thank you very much, CMO. I now welcome Mr. Thomas to provide us with some insight into the importance of the COVID-19 vaccine rollout from an RHA perspective.
Good morning. When the COVID-19 disease began to unfold worldwide, there was a lot of uncertainty. The only thing that we knew for sure was that people were dying worldwide. We asked staff the very critical question: who of you are willing to stand between that awful disease and your household? Staff responded with passion and preponderance. We are, as an RHA, elated at this opportunity to give our frontline staff the protection that is required, this additional protection. I'm confident that the NCRHA has the ability to execute a seamless vaccination process to ensure that the vaccinations are efficiently administered according to the WHO guidelines. Today, we intend to vaccinate approximately 50 persons, 50 to 100 persons across the NCRHA. And vaccines save lives and are part of the arsenal of things that can be done, including the wearing of masks and the other aspects of the COVID regulations. So we again thank the ministry and the minister, and by extension the government of Trinidad and Tobago for the ability for us to be able to arm our workers to engage this COVID-19 threat. Thank you.
Thank you very much, Mr. Thomas. And as you know, on Wednesdays, we get questions from the public. And so it's an opportunity to get responses to those questions that come into us via social media, phone calls, and in various forms. So we go now to the public questions this morning. The first question: how do I know that the COVID-19 vaccine is safe? Just repeating the question: how do I know that the COVID-19 vaccine is safe? And we go to CMO, I think, for response for this.
Let the CMO answer that one.
So as we said, and the minister just said, that we in Trinidad will continue to wait for WHO to approve it by emergency use authorization before we use it. So the robustness of the regulatory system that decides if a vaccine is safe and effective for use across the world has always been with WHO. Through their SAGE group, they continue to look at the efficacy studies through all phases of the trials, phase 1, 2, 3, and 4, to ensure that there's safety and efficacy. If at any stage, whether it's 1 through 4, there's an issue of safety with regards to a particular vaccine, they will pull that vaccine off the market and won't use it in phase 3 and phase 4 trials. So there's that process that has been in place for many, many years, many decades, which we rely on as a regulatory framework to decide if a vaccine is safe or not. And WHO has given approval through the EUA and the EUL for both the Pfizer-BioNTech vaccine as well as the AstraZeneca, being the latest addition, which is February 15th.
Let me just amplify what the CMO has said. To date, ladies and gentlemen, over 150 million doses of COVID vaccines have been administered around the world, the different platforms, whether approved by WHO or not. So between Sinopharm, Sputnik, AstraZeneca, Pfizer, whatever, over 150 million doses have already been administered with little on. I think the figure, the professor who was here, Professor Michel Monteil, had quoted, and when we had the symposium at UB a few weeks ago, one of the doctors said the side effect profile is less than 0.0001%. In other words, it's negligible. But as I said on a press conference here recently, between 3,000 to 16,000 people in the United States die every year from taking NSAIDs like ibuprofen. 261 people died in England in 2018 taking paracetamol. So vaccines are safe, they save lives, and there is absolutely nothing to fear. Thank you.
Thank you very much. And we go to the second question. The second question is: how do I report any problems of adverse reactions after getting the COVID-19 vaccine? Repeating: How do I report any problems of adverse reactions after getting the COVID-19 vaccine? CMO, I think this is yours again.
So there's a process in place. So our standard operating procedure for delivery of the vaccines will mean, one, it should be delivered to persons in a healthcare setting where they are the relevant specialty individuals to support persons in the event that they do get any untoward events. And that will be, our national standard for now is to maintain a person after vaccination for at least 30 minutes in observation to make sure that all things go well for this particular vaccine. If, of course, you leave the facility, you will be contacted through our telemedicine project throughout, at least we're looking at it for a possible period of up to a year to see if you have adverse reactions during that time. Alternatively, if you develop any signs and symptoms in between our contact calls, you can contact our 877-WELL number. You can call if it is an emergency, meaning you have a severe allergic reaction, shortness of breath, or anything else. You contact the ambulance service or you visit your nearest health facility at the shortest period of time.
Thank you, CMO. And again, the third question is yours again. Why do I need 2 shots of the COVID-19 vaccine?
Right. So the 2 that has been registered by WHO need to have two vaccines given subsequently, which is the second dose is usually called a booster dose. We see with other vaccines, for example, DPT, that you need to have 4 or 5 doses after the initial dose. So these are boosters. We call them boosters loosely because they boost the immune response. For Pfizer, for example, when you get the first dose, you get an efficacy of about 50%. When you get the second dose, it goes all the way up to about 90-95%. So it boosts your immune response. The first dose is considered in some circumstance a primer to the second dose. However, there are other COVID-19 vaccines, for example, the Johnson & Johnson vaccine, which is a single dose. And that is based on the efficacy trial and the data coming out of their phase 3, which suggests that their single dose, is as efficacious as it needs to be with that one dose. So there's no need for a booster in that particular case. We saw historically the same thing happen with yellow fever, for example. A few years ago, yellow fever would have been given during childhood, and it was recommended that yellow fever be given every 10 years. With the data coming out of many retrospective studies, about 4 or 5 years ago, or a little bit more than that theory was debunked, and it was actually thought that single dose given during childhood would give you lifelong protection. So WHO would have changed the guidelines, and countries around the world would have changed their guidelines. What is required from that is consistent surveillance of the antibody response. As you know, these vaccines are now being distributed only a few months in the world. So we will continue to follow the antibody response and see how subsequent doses are going. But generally, for Pfizer and for AstraZeneca, they require 2 doses given at stipulated times apart to boost your immune response.
Thank you very much, CMO, for that comprehensive response. And we go now to the question and answer segment for members of the media. Please indicate your name and the media house that you represent before posing questions. Please pose both questions at the same time, and no more than 2, please. And of course, we will try to come back to you if you have additional questions and we have additional time. We begin with questions from AZP News this morning.
Hi, good morning. Priya Bihari, azpnews.com. Minister, my first question is for you. Can you tell me what is the difference between the EUA and the EUL license? With WHO, is there a difference? And my second question is for Mr. Thomas. Mr. Thomas, can you give us an idea of the cost and the personnel that will be used, in this rollout? Thank you.
Okay, so prior, there's basically no difference between EUA and EUL, so that's why I was careful to use the 2 terms interchangeably. But they are basically the same thing, saying that WHO recognizes that this vaccine can be safely and effectively used in a pandemic. Let me give you another example. When the Ebola epidemic, because Ebola never became a pandemic, when the Ebola epidemic was raging in Africa, there was a vaccine being trialed for it. Because the trials showed such great promise and were saving lives in trial, WHO took the brave step in about 2017 to grant what was then called compassionate use. That is, they weighed the risks and the benefit, and they determined that the benefits that the trial showed of saving lives in the Ebola epidemic far outweighed the risks because there was not full approval. So WHO granted what was called compassionate use approval, which is kind of similar to EUA, EUL, until that vaccine was finally given commercial license only in 2019. So you weigh the pros and cons. So I hope that answers your question, and I gave you the example of Ebola.
Thank you. We go to Mr. Thomas for response to the second question, please.
Well, basically, there's no additional cost. The NTRHA already have these teams available to us. As you may be aware, the NTRHA just completed 22,000 vaccinations for H1N1. So those teams there are no additional overheads. Those teams are available to us. The additional infrastructure is there. So we don't anticipate any additional costs associated with the vaccination, save the gas to move the relevant staff to the positions.
Thank you, CEO. And we go now to Wired 868, please.
Hi, good morning. Fayola Bostic from Wired 868. My first question goes to the Minister. Minister, I'm wondering whether or not you the ministry has considered vaccinating members of the government in order to, for continuance of government and also to demonstrate to the population confidence in the vaccine. And if so, when we should see ministers and other people necessary for the governance of the country to be lining up for their jobs. And my second question goes to the CMO. CMO, I'm wondering if you can update us on the talks that you've been having with the TTFA and whether there are any circumstances under which you would consider granting the exemption to the quarantine period for visiting footballers.
Okay, so thank you very much. I will take both questions. So in this initial phase, starting today, we only have 2,000 vaccines, which will vaccinate 1,000 healthcare workers. We are reserving this first tranche only for frontline healthcare workers. I will feel personally responsible if I took the vaccine now, used up that dose, and then a healthcare worker didn't get it and died. So, as we said from the very beginning, the hierarchy of receiving the vaccination is healthcare workers, and not all healthcare workers. We have stratified healthcare workers into those to receive the vaccines from today working in high-risk, high-exposure conditions. So to open it up to government, to opposition, to senators, and then you don't have enough of these important people will be a bit reckless on our part. After we do that, then when we receive the 100,000 doses from the COVAX facility, from the same plant in India, Serum Institute of India, then we could probably look at government persons, ministers, opposition, senators, because they will qualify under essential workers on the same tier as teachers, sanitation workers, and so on. So government ministers and so on, we will be vaccinated later on, but this 2,000 doses, this precious 2,000 doses, is being reserved for those critical, high-risk, high-exposure patients. On the issue of TTFA, I have been in contact with Mr. Robert Haddad, as the CMO has been. He sent me a document on Sunday night, I believe. Yeah. And we have been having talks since Sunday night into this morning. And it is up to the TTFA and or the Ministry of Sport to make the final decision and announcement. Thank you.
Thank you very much, Minister. We go to Express, please. Express?
Hi, good morning. Camille
Wonderful.
Hunt, Express. My question is for Mr. Has the NCRHA met with any resistance from any health workers who don't want to get the vaccine for whatever reason? And also, when will be the next vaccination exercise after today? Is this something that will be going on throughout the week until the 2,000 doses are administered?
So, let me start the answer, and then Mr. Thomas can chip in. So, the first 2,000 doses will be split into two. So each person requires 2 doses. So what we're going to do is use 1,000 doses, generally speaking. So the first dose will be given today, and then we continually roll out until the first 1,000 persons are vaccinated.
Correct.
Across, we're using Couva which is within North Central, as the key hub for vaccination, because 3 out of the 4 major sites fall within the North Central Regional Health Authority. So Couva, as you know, is one of our treatment sites, Cora, as well as Arima. And Augustus Long, which is in San Fernando, also is a site, and they will be getting vaccines to administer to their staff. In the Tobago Regional Health Authority, there are sites where persons have active COVID-19 as well, and they would be getting a portion of the first 1,000 to vaccinate across there as well. So, Mr. Thomas, you could go into details with regards to your section.
Just before we go to Mr. Thomas, the Tobago vaccines, I think there's a regular shipment between Trinidad and Tobago. It will be there on Thursday, so the TRHA can start their rollout, as soon as they receive on Thursday.
Well, the NCRHA spent some time examining the issue of vaccine hesitancy worldwide to give us a sense of the things that, and after discussions with the CMO certainly and the minister on an approach to engage staff. So that is education. So we're educating staff as we speak on the benefits of vaccination, and while simultaneously engaging in the rollout of the most of the persons who are most eager to engage in vaccination at this time. And so one of the things, though, is that special brand of person who stands at the gate between life and death, particularly when we have a virus coming at us, that type of person who volunteered to do that is certainly the bold and the brave. Those persons, I have very little doubt that those persons will hesitate.
Just to complete the answer, members of the media, you may be aware that 2 Sundays ago, we hosted a symposium at 1 o'clock in the afternoon, co-chaired by the University of the West Indies. And that symposium was to address the whole issue of vaccine hesitancy in healthcare workers. What came out of that were 2 things. One, yes, there is vaccine hesitancy around the world, with healthcare workers, Trinidad being no exception. But in the focus groups, what was comforting was that most healthcare workers are just waiting and adopting a wait-and-see approach. And what they said in those focus groups, once they start to see their peers taking it, they are going to follow suit. So it's like a snowball effect. You start the snowball at the top of the mountain small, it gathers speed. So today, we are rolling a small snowball off the peak of the mountain. It will gather speed. We know we will not get 100% buy-in. We know that. That is around the world. That is not unique to Trinidad and Tobago. But I think most healthcare workers will take advantage of this because they understand the science and they understand the need to protect themselves and their loved ones.
Thank you very much. We go now to questions from Newsday, please.
Good morning, Paula Linder here from the Newsday. My first question is for the minister. You said that the healthcare workers had been stratified. Could you give us an idea of what tiers they've been moved into and how many are in the tiers? And have you had any progress in acquiring vaccines from different sources? I know you all were negotiating with the government of China as well as pharmaceutical companies. Have you gotten anything from that? Thank you.
I'll answer the second question, and CMO will take the first question. So we have been in talks with different governments, China, now India. We have also been in talks with several companies having bilateral talks. Pfizer, AstraZeneca, Moderna, Johnson & Johnson. We are also in talks with a CARICOM initiative through what is called the African Medicines Council. Yesterday or day before, we did sign off with our needs analysis for the African Medicines Council, and we have been allocated. It doesn't mean we are going to get her. We have been allocated. We have expressed our interest in purchasing 226,000 doses of vaccines distributed amongst AstraZeneca, Pfizer, and Johnson & Johnson. That is the only one that I have numbers for so far. So we have expressed and they have allocated, in theory, on paper, 226,000 doses. We are awaiting two things from them now: price estimates and estimated time of arrivals. We are also in talks, as I said, with the government of India through the Ministry of Foreign Affairs. We are also in talks with the government of China, but also Sinopharm directly. And once those vaccines from China get EUA or EUL, we'll be in a position to access them. Right? Thank you very much. And the CMO will now take the other question.
Yeah, so there are really only two tiers to the healthcare workers. So there are frontline healthcare workers, like the group we're going to start today, are people who would have been in direct contact with either suspect cases or confirmed cases. For example, those people who work in Cuba night and day with the patients, and they're in those COVID positive environments, what we call hot zones. So those people will be the very, very high risk. Persons who also swab suspected cases on the front line of the health centers, for example, would be people that will be high risk, because they actually do procedures that may cause aerosolization of the virus, and they are increased risk of infection. So that's the high risk of the front line. Other healthcare workers would probably fall into a broader category of general healthcare workers thereafter. So categories, just to give examples, again, people that do swabbing at the periphery in the primary healthcare centers, persons in the accident and emergency departments, those that actually see the positive confirmed cases in hospital, those are your first high-risk tier, and then everyone else will come after as a second tier.
Thank you, CMO. We go to TV6, please. I can't hear you, Ms. Boucher.
Hi, good morning. Alicia Boucher
lovely.
from TV. Alicia Boucher from TV6. Yeah, great. So my two questions. I know that we are expecting 100,000 doses of the AstraZeneca vaccine at the end of March via the COVAX facility, but I was wondering, given that Pfizer was approved by the WHO into the COVAX facility, based on the discussions we've been having with WHO, why is it that Pfizer has not been approved for use within this region? I don't know if you could just give us the answer to that. And then my second question has to do, I know that pregnant women would not be vaccinated, at least not at this time, but how soon after a woman gives birth can she receive the vaccine, even if she's nursing and so on?
Okay. So Alicia, let me just correct something. We never said end of March. We said end of February to the first week in March. That is the COVAX estimate for receiving the vaccines in Trinidad. End of February, beginning of March, that 2-week window. Right. Pfizer. Remember, Pfizer only came into COVAX very late in the game, in January. Pfizer was never a part of COVAX from the very beginning. So that will explain some of the delay in getting the Pfizer vaccine into the COVAX countries. That is one reason. The second reason, and this is where we, I'm using the word suffered in inverted commas, when we got the initial response from PAHO as to why Pfizer was not approved, it is because of two reasons. One, the global shortages of Pfizer vaccines. So they didn't want to send Pfizer, I'm only talking about Trinidad and Tobago now, to Trinidad and not have enough for the second dose. They also found that because of the management of COVID-19 in Trinidad, that it was so good and our death rate was so low, they would have preferred to send whatever small amount of Pfizer vaccines were available to other territories, and that Trinidad and Tobago will receive the AstraZeneca vaccine. So 2 reasons. Pfizer was a late comer to COVAX, and 2, because of how we manage the disease here. Okay? Thank you.
Thank you, CMO. The second question. Yes.
So your question relates to breastfeeding mothers. So, as I said before, and we went through in detail on Monday, and just a quote from the WHO release, it is unknown whether AZT122 is excreted in human milk. So that is still unknown by way of research. Trinidad has taken a cautious approach in the first instance, so we will not be vaccinating, at least in the first instance, pregnant or women or breastfeeding mothers, out of an abundance of caution. So those persons will be not part of our initial drive, and more so we need persons who can be vaccinated to come out and create a protective hood around those people and around the children who are less than 18. So we need a high uptake in the persons that can be vaccinated to create that protective hood around the pregnant and breastfeeding mothers and the children.
How that person was chosen? Thank you.
Okay, so I wouldn't have details as to the first person. We have selected a first batch of frontline healthcare workers. I will be down there at 2 o'clock today to actually see the people, but I don't have a list of the people in front of me now. As CEO Davlin Thomas said, it's somewhere between 30 to 50 people. Okay, thank you.
Thank you very much. And I think we have a follow-up question from TV6.
Yes, Minister, I was wondering, what would you say to some persons who may have a preference in terms of the vaccines that they take, given that we would be getting the AstraZeneca, we don't know when we'd be getting Pfizer. Some persons may opt to wait on another vaccine. Would you advise that they do?
I think that's a clinical question, and I will defer to my colleague to my left, the Chief Medical Officer.
So it really is the vaccines that both the AstraZeneca vaccine and the Pfizer vaccines have been proven to be safe and effective. To varying extents, you would find the effectiveness of in the data. Pfizer suggesting to be slightly more effective in terms of the data than AstraZeneca, but AstraZeneca is somewhere hovering between 60 and 80% at the higher end, 82.5%. AstraZeneca also has research that suggests that it will decrease your risk of transmission, which is something that Pfizer has not proven data as yet. It doesn't have a complete data set on. They have trials ongoing to see what the transmissibility with Pfizer. So again, and when you go back to the science of it, historically, some immunologists have said that the vectors will provide a better and long-lasting immune response. So it might be slightly less in terms of percent, but the immune response may be longer in terms of lasting. It may last longer than the Pfizer vaccine. Only time will tell. So I think it goes down to knowing the science behind it, being properly advised by a healthcare practitioner, and making an informed decision as to which one you want to take. But both of them are very good vaccines. They're both WHO approved. They're safe and effective. And I think either one can be used, of course, bearing in mind the contraindications if you fall into one group or the other. But both of them are very good vaccines that can be used safely and effectively to prevent COVID-19.
So Alicia, I think the lesson to be learned there is don't wait. There doesn't seem to be any benefit to wait for one over the other. So I think the lesson is whichever one of the two is available, take it.
I like that, Minister.
Yes,
we go now to AZP News for another follow-up question, please.
Just to follow up, a little, on Alicia's question. So the AstraZeneca vaccines that are made in India and the ones that are made in South Korea, there's no difference in them. They are both the same.
Right. So what AstraZeneca would have done is, of course, look at manufacturing sites, so alternate manufacturing sites for the production of the vaccines. The two sites that are approved by WHO is the South Korean site, and there's one site in India, which is the Serum Institute. Both sites, usually when you approve a vaccine, the regulatory agency actually visits the country and the manufacturing plant. They do a site visit to that plant, making sure their quality assurance, quality control mechanisms are in place. They actually spend some time and see what the processes are like, making sure there's no room for error in the production of the vaccines. So vaccines and drugs in some instances are given approval, not by a manufacturing site. And that is the case for Trinidad's regulatory approval as well. So we do it by site. So we will follow that lead from WHO, and the vaccines that we will use would be either from the South Korean site or from the SII site in India.
Thank you, CMO. Newsday, I think we have a follow-up question from you as well.
Yes, my question is to be careful. Are the topics of carnival like celebrations that had over and for concern of increasing cases in the
Okay. All right. So, I mean, since the beginning of the epidemic, we would have noted whenever there was some sort of gathering, we would have been cautiously looking to see if there was a surge or increase in number of cases thereafter, maybe 14 to 21 days after. We want to underscore, of course, that the regulation is still there with regards to 10 persons. Shouldn't gather more than 10 persons in any particular given space. Of course, wear your mask is mandatory and is law at this point in time in public spaces as well. But any gathering that exceeds that and persons not wearing their masks is a cause for concern, because it is a great risk to spread of the disease. What we are keeping an eye on, really, schools have opened now as of the 8th of February, and it requires a large number of people coming out that would have been home before. So that is what we are looking at epidemiologically and paying some attention to. We're looking at early next week to possibly see, or late this week, to see the beginnings of an increase if it is to come. But that will be based on how well the guidelines are being adopted and adhered to in the schools.
Thank you very much. Wired 868, another follow-up question, I believe.
Yes, thank you. Follow-up question here for the CMO. We've gotten reports that there's another UK variant that was detected. And I'm wondering, with the emergence of these variants, as you know, the virus mutates, I'm wondering whether or not, like, how likely is it that in the event there's not herd immunity achieved throughout the globe, how likely is it that we'll have to keep taking the vaccines, perhaps like the way we take the flu vaccine right now?
Nice question.
Right. So, it's a good reference to the flu. So basically, as you know, the reason we formulate a flu vaccine every year is because there are mutations that occur in viruses. So every year it has been proven that the flu vaccine will decrease in efficacy from year on, 1 year to the next, if you don't do changes to that particular formulation to accommodate the mutations that would have occurred in the previous season. Similarly, and because we only just started to give the vaccines and we don't have that data as yet, we can postulate that there may be a similar response with regards to this particular vaccine, COVID-19. It's a respiratory virus as well, and there have been significant mutations across the world, over 100 mutations already noted. But what we call variants of concerns, there are only possibly 3 or maximum 4 variants of concerns, meaning there's a change in the way the virus behaves by way of transmissibility or by way of the way it causes morbidity and mortality. So again, it's something that we have to wait and get the data on, because it's only now been rolling out across the globe for a few months. We have to watch. There has been some early studies that suggest some of the variants will decrease the efficacy of the viruses, and hence the reason we're trying to, one, keep the variants out of Trinidad and Tobago and vaccinate as many people as we can in the shortest possible time. So we afford them the protection to the existing strain, and hopefully, even if there's a new strain that comes in, there will still be some degree of protection offered by the vaccine to those individuals. But time, as I say, we have to wait some time, see what studies come back with regards to the variant and the efficacy of the vaccines. And of course, if new formulations need to be done, then those companies will have to make adjustments to the vaccines to cope with the variants of concern.
Thank you, CMO, for that clarification. ACP News now, please.
Hi, good morning again. Minister, I just wanted to find out how it is Barbados was able to get vaccines before us. What did they do that we didn't do?
Okay, so
thank you.
It's not that Barbados got vaccines before us. This was a gift to the region from India, and they used Barbados as a focal point or a central point. Okay, I hope that answers your question prior.
Thank you. Now to Newsday, please.
My question is, at one point, the families of elderly in home were hesitant about allowing the vaccine. Has there been a case in it?
Hi, sorry, Ms. Lindo. We're not understanding your question, unfortunately. The connection seems to be a bit static. So try again. Try just to be a little clearer. It's the connection, not you, but maybe we can hear you. Get the gist of the question if you try again.
Not here.
Okay,
No.
so we're definitely not hearing.
Right. Sorry.
Just a little louder and slower, we may be right.
The families of elderly people who are in elder homes were hesitant about allowing them to take vaccine. Has there been a change in this mindset with the education that they have to do?
Okay, so the question that we heard was that there was some resistance from the families of persons in the homes to have their elderly persons vaccinated, and you're asking if there's been a change in this mindset, yes? Okay, great, yes, that's the question.
Yeah, so we would have received correspondence from the presidents of the association dealing with that particular issue, indicating that they were in the process of doing consent forms to the relatives of those persons that were in the homes. We haven't received any feedback from them since, but they have communicated that they're in the process of sending out the consent forms and getting those consent forms back at the homes. Mind you, the consent form is not something generated by the Ministry of Health. It was done by the association for their membership. We don't require written consent for the vaccine in this case.
Thank you very much, everyone. We have come to the end of this morning's media conference. Thank you for your participation. It was an important conference, and today's an important day for the country. Please remember to tune in to media channels at 2 p.m. today for a live broadcast of the administration of the first COVID-19 vaccines in Trinidad and Tobago. Everyone be safe. Please wear your mask. We end with a video from WHO entitled Vaccines Explained.
Hello and welcome to Science in 5. I'm Vismita Gupta-Smith and this is WHO's Conversations in Science. We're going to continue our conversation on COVID-19 vaccines, and explaining the science and evidence behind it is WHO's Chief Scientist, Dr. Soumya Swaminathan. Welcome, Soumya.
Thank you, Vismita.
Soumya, we're going to start with a question that we get quite often. If I have already had COVID-19, do I still need to be vaccinated?
We know that most people who have COVID-19 do develop an immune response, but there is a subgroup of people, particularly those who have had very mild infection, and sometimes they don't even know it, it's asymptomatic. Those people we know have a less strong immune response compared to those who've been seriously ill and get good antibody response. So in general, we are now recommending that people should get a vaccine if they fall into that priority group, regardless of the fact whether they've had a previous infection or not. And the good thing is that, the immune system recognizes the same antigen, the same protein. So even if you've had a previous infection and you now get a vaccine, it acts like a booster and it boosts that immune response, both the antibody response as well as the T cell response. And so you're much more assured that you have a good immune response and that is going to last for a long time. Of course, how long this immunity is going to last is something that researchers are still looking at. We don't know the answer to that. But at this point, we do recommend that you get a vaccine whether or not you've had a previous infection.
Soumya, another common question that we're getting is that the current batch of vaccines against COVID-19 is not for children under 16. What is the reason and the science behind that?
So whenever new drugs or vaccines are developed, they go through this clinical trial, right? The testing in people with the disease in order to make sure that they are both safe and effective. And this usually starts with adults because in case there is an unexpected